Thank you for the opportunity to present what have we learned from the pandemic lockdowns. I will move straight to probably two messages. One is of disruption and one is of the innovation. And I will start with the disruption. We have seen major disruption in the HIV programs and also related programs across Europe and across the world. The biggest impacts have been on HIV prevention, on HIV testing, and also referral among the HIV services. But if we look also at programs like tuberculosis and like hepatitis, but tuberculosis in particular, there have been even more disruption probably there. For example, in Europe, the level of notification have decreased nearly by half, and so did the enrollment in multi-drug resistant tuberculosis treatment. If we compare 2020 with 1 year before, and especially that was the case in May. With HIV, we don't have that statistics for Europe, but we know, major analysis done by the Global Fund with among the 500 facilities showed that there have been testing reduction by 41% and referrals indeed more than by 1/3. So why those changes and disruptions happened? One is because human resources, lab, other infrastructure, so resources were redirected from other areas, including HIV, but particularly TB, to COVID. Secondly, non-essential health visits and services were postponed and people were asked not to come. Thirdly, to access HIV prevention, there were restricted possibilities for people who needed them, like people who use drugs, sex workers, gay and other men who have sex with men, trans people. For them, the movement was restricted. And to explain why they're going to HIV prevention sites was a rather complicated issue. And we heard reported problems from the ground. Fourth element is that medicine procurement and overall supply procurement was much more complicated during the COVID, and especially in the first wave, but we see the continued challenges, which meant that there was much more management needed, much more planning in advance. But also in some places, there was actual interruption of medications like in Ukraine or Georgia. And that was linked also that borders locked down, like in India or like Italy, and Italian methadone could not reach Moldova. So these changes were taking place because of those four elements. Importantly, when it comes to HIV, the impacts have been different in different countries. And that is because the measures, the restrictions have been different even within the European Union countries, but also what is essential services that should continue to operate despite lockdowns was defined in countries differently. In the Baltic states, Estonia and Lithuania, my home country, there have been different definitions whether HIV testing should continue and is essential, or HIV testing basically discontinued in my home country because it was seen that it is not essential at the point. So we heard of the disruption. Now let's look at the two elements, the changed needs and how services adapted and how much flexibility services demonstrated to alter and to meet the new needs and new realities. First, people who are served, that people who are vulnerable for HIV, their needs have changed much more. Social needs have been increasing in terms of demands like food, water, hygienic supplies, or also shelter. In terms of health, some elements that have been less clear, less articulated before, increase or something that was not as needed, or protective gear was something that was demanded and services had to try to deliver that. But overall, there was limited information understanding how services, how access to healthcare is operating during the lockdown. And mental health needs have increased. The realities change in terms of drug scene, in terms of gay scene, sex work. Many sex workers were just not able to work, and they stayed without income. In terms of prisons, where HIV is also is prevalent, especially in some settings, there have been lockdowns to try to contain the COVID. And that meant that in a number of settings, HIV organizations could not access prisons, like nobody could access prisons with very major restrictions. And initial rules in particular have been rigid and nearly impossible. For example, for homeless people, there were situations where the shelters closed, but homeless people were asked, among others, to stay at home, but they did not have homes or places to stay. The other element that changed are the models of service delivery. And let's start with prevention and testing. Online outreach have been really something used, contactless delivery of syringes and needles, of condoms, mobile services. There have been much more use of that in some settings at least. And finally, if in the past we saw much more restrictive prevention supplies issued, for example, 5 syringes that are clean, if you brought 5 used syringes. So now there was more supplying in bulk. Furthermore, when it comes to prevention and testing, self-testing and reliance on the community-based testing has really increased during the epidemic, but self-testing in particular. Prevention settings took more measures for infection control and found creative ways how to increase control, sometimes with very limited means. And last but not least, there was more inspiration for greater integration of HIV services and link services, and also thinking about optimization. This was rather limited, but for example, Moldova, just before COVID started, changed its diagnostic algorithm for HIV without Western blotting, as the World Health Organization recommends, and they managed to implement it much quicker, I think also in part because of the COVID. And what's important that some of those services managed to reach new people who were not reached before. For example, self-testing in Poland said to reach 50% of their clients with self-testing were those who have never been tested before. If we look at the models of service delivery for treatments and support, there are probably 2 major areas that would be important to mention. One is delivery of medicines. For how long? So the periods became, like for antiretrovirals, month-to-month dispensing became popular, but also with opioid agonist therapy, daily visits no longer were requested by a number of countries like Georgia. And people finally got medicines for 5 days or so. Home delivery, electronic prescriptions, refilling antiretrovirals in pharmacies is something that also became quite a regular practice. And furthermore, of course, online support. For TB, we knew, and it was quite well used and researched, that video observed support gives very good results. So that became applied in some settings really widely and really quickly, but also other ways of online counseling and phone counseling, from WhatsApp to mobile apps to also using mobile apps to learn when your results for viral load are there, reminders for taking medicines, etc. Opioid agonist therapy, we saw that more people who use drugs and who have dependence on opioids or other needs in relation to opioids, they came for treatment. And that is the case in, for example, the United Kingdom, in Germany, in Lithuania, and other countries. So that's good news that more people requested. In terms of moving forward, on one level, we know much less what happened with HIV because of the disruptions of 2020, and especially in countries where we use reported HIV cases as indicators whether HIV is increasing or reducing. We cannot use 2020 data for that indication what's happening with the trends because we tested fewer people. But what we know, and especially with the tuberculosis, but also HIV, that we lost opportunities to diagnose people. So we will need to catch up for the lost time. In case of tuberculosis, the estimation is that 1 year has been lost. We went down, so we will need at least 1 year to catch up. And then we can progress to the ambitious agenda for ending HIV, TB, and hepatitis as the public health issue by 2030. Secondly, with disease preparedness and public health in health systems, what we learned that we need much more inclusive planning, where service providers, civil society, and communities would play the role. And furthermore, that community-based services and NGOs should be included into the definitions, what are essential services, what are essential workers, and make sure that they are recognized as part of health systems. Furthermore, WHO recommended service delivery models saw some faster introduction, probably faster during COVID than before. But the question is whether they are there to stay and could it be used more. I think we need to think more about self-sampling and testing, also addressing pricing issues. We need to update national guidance to ensure that some innovations are put into institutionalization based, of course, on evidence, what we saw in terms of integration, in terms of simplification of delivery of services, dispensation, flexibilities, and we know that like multi-month dispensing, for example, in Kazakhstan, Columbia University, saw that the results for the viral load suppression are actually very good. So updating national guidance and digital capacity needs to be addressed for both service providers and clients, patients, and also thinking about, quality assurance of all those new innovations. If we put them into regular practice, how we account for them, how do we make sure that it is not only emergency approach, but it is actually the quality care. And make sure that monitoring systems also are adapted to that. So our databases, how we track and report on things. And I think we can take the COVID and the possibilities of responsiveness as the sign that especially we in Europe, but also Central Asia, we should be more alert to innovations and open to recommendations that are coming from World Health Organization, often that are implemented these days much faster in such settings like in Sub-Saharan Africa or in Asia, and much less than faster in Europe. And of course, we need to monitor the needs of people with HIV and key populations with flexible funding adapted to include them into the recovery and life with COVID in our measures. And last but not least, I wanted just to say that, there have been quite few reports that indicated what was happening with COVID, or what happened with HIV and TB services. And just appreciate all those reports which have been used for producing those slides. Thank you very much.